Our next presentation is by Rhoderick Machekano, Comparative HIV Risk Screening Tool, Performance of a Validated and Alternative Optimized Tool for Children and Adolescents in Uganda, Tanzania, and Malawi. Please, Rhoderick, go ahead.
Thank you. I would like to thank the organizers for inviting me to present this work, which we did with a team of, a large team of collaborators, the largest team I've worked with, as you will see from the acknowledgements. The title of my presentation is Comparative Performance of a Validated and Alternative HIV Risk Screening Tool for Children and Adolescents in Uganda, Tanzania, and Malawi, a pooled analysis. I have to say this is a presentation of secondary data analysis resulting from a number of studies that were done separately, and we are trying to maximize the benefit of more data to see which tools can best be used for HIV risk screening.
Do you see the slides? Can you move them?
All right. Thousands of children living with HIV present to health facilities daily, yet many remain untested, undiagnosed, unaware of their HIV positive status. Now, we have received a background information on the current epidemiology of HIV in children and adolescents. Globally, there are an estimated 1.7 million children living with HIV. Now, despite these, such a large number of children, only 54% of the children are on ART, which is very low coverage compared to coverage in adults, which is about 74%. These graphs gives us the number of newly infected children as in up to 2020, showing low EID coverage at 2 months, around 63%, and high mother-to-child transmission during breastfeeding. Now, the delay in diagnosing these children limits the opportunity to get infected children on treatment. At the same time, the WHO recommends universal testing among children presenting at health facilities, especially at entry points such as TB clinics, nutrition clinics, and immunization clinics, as well as other outpatient settings. However, this approach may face operational challenges related to funding, testing efficiency, particularly in countries with low prevalence of HIV among children. Moreover, universal testing in general outpatient settings may increase health worker caseload, thereby compromising testing of high-risk children and consuming testing resources unnecessarily. Now, HIV risk screening tools in outpatient departments and community settings provide an opportunity to improve diagnosis, ensuring children with the highest HIV risk receive testing and treatment initiation among newly diagnosed children. This is an example of an HIV risk screening tool from Zimbabwe that was developed and validated by Banderson and colleagues. The tool is based on these 4 questions. Has the child ever been admitted to hospital? Has the child been sickly in the last 3 months? does the child have recurring skin problems, and has any of the child's biological parents or siblings died? This tool, when it was validated in Zimbabwe, it had a sensitivity of about 80%, specificity of 66%, positive predictive value of 10%, and a negative predictive value of 98%. So we set out to evaluate this tool in the 3 countries of Uganda, Tanzania, and Malawi, countries with different epidemiology, to see how the tool performed. And so our first objective was to estimate the performance of the Zimbabwe HIV risk screening tool in Uganda, Tanzania, and Malawi, as I have said, by estimating its diagnostic performance, looking at sensitivity, specificity, positive predictive value, and the number needed to test. We also examined the effect of including biological parent or sibling HIV status to the Zimbabwe HIV risk screening tool. And all these analyses were disaggregated by country and setting being either clinical setting in the OPD or in the community screening in the community. The second objective, we used data-intensive and machine learning approaches, including least absolute shrinkage and selection operator, known as LASSO, on the pooled data, restricting to Uganda and Tanzania, because in this group, we had many more questions that were used for screening. So, but Malawi only restricted the questions, the screening questions, to the 4 Zimbabwe questions. So in order to develop another tool, we only restricted it to Tanzania and Uganda. So data was split into a training set and a validation set in the ratio of about 90 to 10%. And then we assessed the performance of the selected screening model using the area under the curve. Now, the area under the curve summarizes how well a tool discriminates between true HIV-infected and uninfected children. And an area under the curve greater than 0.8% is usually considered to be satisfactory, with an area under the curve equals to 1, indicating a very discriminative tool, and obviously an area under the curve of 0, indicating that the tool is completely useless, to be kind.
2 minutes left.
So moving to the results, so we can see our sample was, there was balance between gender and age distribution across the countries. And this is a graph showing the distribution of the HIV signs and symptoms for the 3 countries. And we see that in Uganda and Malawi, the highest or the most common symptom was sick in the last 3 months. But we can see that there was wide variation between countries in the symptoms. So evaluating the tool between the 3 countries, we see that in Uganda, sensitivity was 90.9%, in Malawi 73, 65% in Tanzania. And while the tool, as evaluated in Zimbabwe, it was 80% sensitivity. And again, we can see the difference in the specificity between the countries. The graph on the right shows you the number needed to test, which was much lower in Uganda, a little more in Malawi, and a very high number needed to test in Tanzania. So examining the effect of including the maternal HIV status, we saw that it significantly improved sensitivity across all the different age groups. Now, the alternative risk screening tool that we developed, we found that we only needed to ask about three symptoms. If the child had growth problems, at least one biological parent or a sibling was HIV positive or unknown HIV status, and if the child had recurring skin problems. Now, a simple yes rule to any of these would result in a child being tested. Now, this tool has good discriminatory performance with an area under the curve of 0.84, and we also noted that this tool is more suitable for use in OPD settings, yet performance varies across countries based on HIV prevalence. So this shows the comparison of the diagnostic measures, sensitivity, specificity between the Zimbabwe HIV risk screening tool and the alternative optimal tool that we developed. And we can see that the alternative tool performs better in all diagnostic measures. These two graphs shows the performance of the optimal model between the two countries, with very good performance in Uganda, but poor performance in Tanzania. Again, comparing the performance of the tool between OPD and community setting, we found that the tool performed much better in the OPD setting. We also developed an alternative tool for the older adolescents. Again, the same sort of risk factors were selected, except the first one where child growth was replaced by child being sickly in the last 3 months. However, this alternative tool had poor discriminatory performance with an area under the curve of 0.74. Now, in conclusion, we can see that screening tools may offer more benefit among children less than 15 years compared to older adolescents. Variability in tool performance was affected by differences in pediatric HIV prevalence, which was 1.6% in Uganda, 0.8% in Tanzania, and 0.4% in Malawi. So Tanzania and Malawi had lower HIV prevalence among children and adolescents compared to Uganda. The tools may offer more benefit in settings with higher HIV prevalence. So I would like to acknowledge our large team of collaborators as well as funders for this study. Thank you.
Thank you.